Thank you so much for joining us today at the Pandemic Toolkit and Vaccine Updates for Christian Leaders webinar. I'm sure you've all been on 1,000 Zoom webinars at this point, but as a reminder, your video and audio controls are controlled by the icons on your screen. This webinar is being recorded. Please mute your microphone when you're not speaking in order to reduce background noise. And if you experience any difficulties, you can go ahead and post a message in the chat or email our facilitator, Susan Palevsky, for assistance. You'll get an evaluation emailed to you after the webinar, and the recording will subsequently be mailed after you complete the evaluation. I'm going to turn the mic over to Peter Gudaitis for a brief welcome.
Good afternoon, everyone. I'm very grateful that you've found the time in your schedule to join us today. And I first want to acknowledge our co-sponsors, the Greek Orthodox Archdiocese of America, and joining us this morning from the Archdiocesan Office is Father Nicholas Kazarian, as well as the Salvation Army, Greater New York Division, represented by Zach Hodgson, who's the Director of Emergency Services, and Major Stoops, who will be saying a few words in a few minutes. As you all are aware, the Mayor's Office has also been a long supporter through faith-based initiatives of these types of trainings as well, and so we're grateful for their support. This project is actually funded by the Department of Health through the Fund for Public Health of New York City, and it is directed at helping share the most recent information available during the pandemic. And this toolkit is part of that initiative. And so Susan Palevsky, my colleague, and Gabrielle are our two staff who work on our faith sector community preparedness program, and they'll be taking you through the information for the day. I do want to point out that I'm sure you are all aware that news changes about the pandemic, sometimes hour by hour every day. And so what we are offering is some of the core information that does not change, but also recent vaccine update information that does change quite frequently. There are new vaccines, one today coming online. And there's also new information about availability of vaccines and where vaccines are being distributed in New York City. And I also think it's important for all of us who are religious leaders in this city to also talk about the disparities in where vaccines are available and what are the facts about the vaccines that are available. In New York City, you are twice as likely to contract COVID and die if you are Black, 1.5 times more likely to contract COVID-19 if you are Latino, and white and Asian New Yorkers have a similar risk factor. So paying attention to the populations in New York City that are most vulnerable and how we advocate for equity in that distribution is a key part of what we hope that you'll take home to your congregations at the end of this presentation. I realize the presentation on preparedness might sound a little late to the game, but I will simply say that the pandemic is far from over. And how we continue to prepare our houses of worship and religious nonprofits for the threat and the evolving threat of the pandemic is why pandemic preparedness continues to be a relevant topic. And once we do achieve herd immunity, hopefully, we will have a very long period of recovery time ahead where faith communities will also continue to play an important role in healing, in establishing hopefulness, and supporting those in crisis as they navigate the recovery process. The evolving threat, as you all are aware, is the way the vaccine is mutating, which is normal for a vaccine to mutate, but that mutation presents ever-changing risk. At the moment, it's not more fatal, but it spreads more quickly. And so part of preparedness for our congregations is about preventing spread. And then I just want to briefly touch on herd immunity. In order for the United States to achieve herd immunity, 80% of our population must be either vaccinated or have natural immunity from being infected. More than a quarter of our population is children under the age of 18. The current vaccines are not available to children under 18. And there is testing going on to prove that it's safe for children, but as of yet, it's not. So that would mean every single adult and 5% of our children would need to be vaccinated in order for the United States to achieve herd immunity. That is a daunting prospect, because we live in a culture where we have an anti-vaxxer movement that is quite robust, and about a third of American adults have already said they are reluctant or they will not take the vaccine. So part of our role as faith leaders is to share accurate information about the vaccine, encourage vaccine use compassionately and with accommodation for those who will not take it for religious reasons, but to also be clear on what the vaccine science is. And so we're grateful that Hannah, our colleague from the health department, is with us today, Hannah Arnett, who will be talking about the current vaccine science and information available so that we can be sources of leadership with accurate information for our congregations. So I will leave it there and turn it back to Gabrielle. But again, thank you for joining us today. Thank you to our co-sponsors, and we look forward to your evaluations at the end of the hour together. Thanks so much.
Thank you, Peter, for that informative and timely welcome. I want to pass it over to Father Kazarian from the Greek Orthodox Archdiocese. Father Kazarian, would you like to say a few words?
Yeah, sure. Good afternoon, everyone. I'm sorry, the snow took away my voice. So I hope you're all doing well. I'm Father Nicholas Kazarian from the Greek Orthodox Archdiocese of America. We are pleased to be co-sponsor of today's webinar. And like many of you, our communities and their members have been exposed to the awful consequences and its many challenges. And as Christian churches, we try to respond to this tragedy. The Greek Orthodox Archdiocese has offered online toolkits to parishes and the faithful to better equip them throughout this challenging time, especially supporting the transition from in-person services to online services. We also organized a COVID-19 relief fund and distributed over $600,000 in assistance to more than 350 people, regardless of personal origin or religious background. A similar fund has also been created for parishes in difficulties. But these would not have been possible without your work, the work of New York Disaster Interface Services, which allows us to concentrate our energy, on these specific projects. I would like to commend all of you, Suzanne, Gabrielle, Peter, and the others behind the scenes for everything you do, your dedication, and for offering us, Christian communities and faith-based organizations, this opportunity to get good information and to be educated on how we should respond to the vaccine. So thank you so much, and sorry again for the voice. Thank you. Have a good webinar.
Thank you, Father Kazarian. We're so grateful for all the work that the Greek Orthodox Archdiocese have done to support local parishes at that time, and we're happy to be of service to you. Mr. Zach Hodgson is here from the Salvation Army. If you'd like to say a quick hello.
Yeah, sure. I have my voice, but I barely have my back. That's what the snow did to me. Just a quick thanks for joining the webinar. I've had the chance over the last 15 years or so to partner with some of the work that NIDAS has been doing to build capacity into the faith sector in New York City around disaster preparedness, and I know that they have good resources for you today. And any way that our sector can partner with the Department of Health to be part of the solution and vaccination efforts in this pandemic is time well spent to learn more about. So thanks so much for joining, and I'll stick around as long as I can.
Thank you, Zach. Thank you so much for your support.
Yeah.
So moving into the content of our webinar today, the toolkit will be the main focus, and we'll go over how to use the toolkit, the process of describing community stakeholders, plans for communication, plans for continuity, templates and tools that the toolkit offers to you, as well as time for vaccine updates, additional resources, and some questions and answers. I want to acknowledge that at this point in the pandemic, we know that you all are experts in adjusting to the circumstances at hand, and that you've come up with really creative ways to do that and to keep your parishioners and yourselves safe. We're hoping that we can add to the already robust resources that you all have developed and that we've been sharing with one another. And I'm hoping that this will be as interactive as possible, and there will be time to share some of the best practices that you all have developed throughout the past year. We're going to start off with this poll question. Is your congregation or community using a written emergency plan during this pandemic? Susan, can you cue the poll for us? The votes are rolling in. Excellent. All right, so we have a even split 50-50% response in terms of who is using a written emergency plan and who isn't. I'm curious, for those who are using a written emergency plan, you can either unmute yourself or type it quickly in the chat. Is that something you had in place prior to the pandemic, or something that you developed specifically to meet the situation at hand? All right, so Matt Schaefer responded that this was something that was developed during the pandemic, that the pandemic spurred his community to create this. All right, Jeff Quarter is saying the same thing. Okay, so it seems like the pandemic is perhaps a tool that we've used, as challenging as it is, to also be prepared better as future responses as future situations might arise. The toolkit is particularly special because it has been adapted for New York City faith communities. This was a DOHMH manual that we rewrote in order to be most applicable to our constituency. And it includes considerations for congregational stakeholders and structures, for ritual and religious worship, for those congregations who provide social services, and has lots of these easy to use worksheets that are really helpful and help you to do that planning. This is just an overview of where you can find things at a glance. And here's an example of what a page in the toolkit looks like. The blue boxes will tell you where to find the template documents that your congregation can use for its own plan, whereas the gray boxes share other pages of the toolkit which you can cross-reference for the same topic. When we start planning for a disaster or for any kind of response, we need to first identify the groups of people that we should be planning for during this time. These are typically divided into two groups. This can be leadership and staff, which would include you and any other paid employees as well as volunteers. And this would also be a separate plan for congregations, clients, and contacts, those people who might not need all the same internal information, but who still need to be informed. Keeping track of your leadership and staff is a lot easier if we use an organizational chart. We have an example here that shows the hierarchy of a church that has a reverend as well as an assistant reverend. This differs, of course, depending on your organization. Sometimes we might have two co-pastors or a different structure, but this can help us see the way that information flows and needs to be disseminated. The template for this can be found on page 90 of the toolkit. When we plan communications for leadership and staff, some things we might want to consider including are continuity of operations, who covers which positions if the normal person becomes indisposed, delegation of authority, who is most qualified in an emergency if key leadership are not available, human resources policies around sick leave and working from home, info regarding vaccinations, training information now that everything is virtual. Where does it happen, when, what, personal and family preparedness information, as well as general hygiene information, such as washing your hands, covering your cough, wearing a mask, all of those important details. When we're planning communications for our congregants, clients, and contacts, this might change a little bit. You're going to want to include changes to all of the services, programs, rituals, and religious worship that happen in a given week, as well as special hours of operations or different methods for delivering services. Maybe pastoral care has switched to virtual only. How are people accessing personal protective equipment to keep themselves safe? What are the rules around that? Again, the general hygiene information similar to what you shared with your staff. Info about the vaccine, government service locations, points of dispensing for the vaccine, partner organization information, other places that people might access services, as well as government assistance information. Where can people get help with rental costs, utility costs, all of the things that become challenging in a situation like this one. After we've identified what we want to communicate with our staff and leadership versus our congregants, clients, and contacts, we then want to determine the most effective method for communicating that information. And this might differ depending on the target audience. For leadership and staff, this can include social media, as well as email, memos, in-house posters, conversations, presentations. And for congregants, clients, and contacts, we might be using software like Constant Contact, updating our website or Facebook, posting flyers outside, holding webinars, or conducting conference calls. Our next poll question is, what forms of communication have you used during the pandemic? Check all that apply. All right, the votes are coming in. Excellent. So we can see that email and text message are the most popular and indeed used by everyone forms of communication, followed closely by other electronic methods, although we do still have some people who are having direct conversations, which can be important for people who have limited access to technology. When we move into the supplemental documents for the planning communications, you'll see this template that explains the 6 basic emergency message components, which include expression of empathy, clarifying facts, what we don't know, the process that we want to follow to get answers, statements of commitment, reminding your community that you're there for them, as well as positive action steps that are really clear. We want to remember who the audience is when we plan these communications and what their relationship to the incident was. If they're personally affected, perhaps loved ones have died of COVID, and we need to be particularly aware and sensitive of what we're saying. We want to make sure that all of our messages are culturally and linguistically appropriate, and that the level of emotion that we're communicating is appropriate. This is really supposed to be informative. We're giving facts. We are dispelling any rumors that might have happened, and we are avoiding jargon, judgmental phrases, too much humor, or extreme speculation. This chart on page 91 helps plan how your congregation will communicate changes to worship services, programs, and other information. It's an easy tool to help us organize when a lot of messages are going out at the same time. The templates in the toolkit are form documents that have a lot of basic content already in place, but they leave information specific to your needs blank so that you can fill them out for your community. And these include get ready for COVID-19, if you're not feeling well, staying healthy, and changes in congregational programming. During a pandemic, the celebrations, rituals, and ceremonies, weddings, rites of passage, observance of holy days that your community ordinarily counts on will require creative and patient reworking. Plan ahead for how you will maintain as effectively as possible the required rituals, prayer, study, worship, that give meaning, structure, and dimension to your community life. While we're planning, we want to identify essential functions. What are the things that need to happen, as well as orders of succession, who's in charge of completing those essential functions. If the typical person is unavailable, who will succeed that person, as well as delegations of authority, which defines who has the power to put someone in charge of something they aren't usually in charge of. The essential functions are those that have to be performed during or immediately after an emergency, and we want to separate those from non-essential functions that can be deferred until the situation calms down. Mission essential functions are those that are essential and also directly related to accomplishing the congregation or organization's mission, whereas essential support activities support those mission essential functions. Examples of this: a mission essential function would be ritual life, like regular worship service, and a supporting activity for that would be maintaining the ritual objects, prayer books, sacred texts, and garments. This is essential, however, it doesn't constitute the service itself, and therefore it supports the mission. A deferrable mission or function might be providing general religious education. It's important and it might be considered part of our mission. However, we might decide that operating community-based programs that are not contributing to life safety can be deferred until a later time. And the supporting activities that go with that, class rosters, orders of supplies, etc. I wouldn't be surprised if many of us had canceled religious education toward the beginning of the pandemic. And then as we got more used to the rhythm of digital worship, digital services, perhaps we've added in new virtual opportunities for religious education in the meantime. Other functions that may be considered essential include providing spiritual, emotional, and social support, facilitating prayer and worship services, maintaining social services for special populations, conducting rituals related to death and dying, performing religious rituals related to birth and cleansing, as well as wedding ceremonies. We've gotten information from the state recently that wedding ceremonies will be able to continue starting in March or April. So that's an in-person activity that we might see returning as communities feel that it's safe. Other essential services include coping and safe practices among your staff and those you serve. How can we promote staff to be healthy and care for themselves? Maintaining disaster-specific personal self-care practices, recruiting specially trained caregivers and social service volunteers, practicing reciprocity between faith communities to provide essential services. If your resources are getting stretched, how can you partner with other churches and communities in your denomination or perhaps ecumenically to provide those services? Also communicating risk. It's really important that we're offering timely, accurate information that seeks to inspire, inform, and educate, that we're meeting fear and anxiety with empathy, reassurance, and calm. We're addressing rumors and misinformation and offering our approval for safer alternative religious practices. The next poll question is, does your congregation have an order of succession or delegation of authority plan? All right, so we have 2/3 saying that we do not have an order of succession or delegation of authority plan, and 1/3 saying yes. So perhaps that's something that you'll get out of this webinar today. You'll be able to go back to your congregation and create that plan so that there is a clear order of operations for what happens if you or whoever's in charge is not available. We have a chart on page 53 of the toolkit that helps you learn how to create this plan and maintain your essential functions during an emergency. This continuity of operations plan template is an example for a congregation with social services. So in this case, we've identified the person who is responsible for sacred music, and then put in 3 alternates for who can take over their responsibility should they become indisposed. Then we have the director of a feeding program, the feeding manager, as well as 3 alternates for that person. Here we have a special note about volunteers. Volunteers present unique challenges during an emergency. Many have regular paying jobs which they must perform. They may use their free time or time off to conduct their voluntary activities and may be unavailable to perform their duties even if they aren't ill during a pandemic, but because their regular job has more need of them due to the pandemic. If your congregation or organization relies heavily on volunteers, then consider checking in with them in the early stages of a pandemic to communicate the following: reinforce the message about personal preparedness and household planning, find out if they need assistance, and check on their ability to assist your congregation if and when needed. Additionally, you should check if congregational volunteers are in a high-risk category identified by your local Department of Health. You should check to see if they're able to continue this work at all during this time, and encourage volunteers to consult with their healthcare provider should they have concerns. In terms of planning for our staff, prevention is one of the most effective methods to ensuring as many staff are available as possible during a pandemic, and the following measures can help prevent a pandemic like COVID-19 from spreading through the staff. You want to provide as much factual information as possible, encourage vaccinations and healthy activities like hand washing and social distancing. Make sure everyone knows what is expected of them before a pandemic, and make it easy for staff to find out about things like sick leave and working from home. It also might be necessary to adapt human resources policies like those that require a doctor's note in order to reduce the stress on our healthcare system during a time like this. This is also an important time to make sure that we have staff who are cross-trained so that they can easily take over one another's duties if someone is out, and that it's clear that who is in charge if there's a change in leadership or authority. It's also important that we're publicizing any medical, mental health, or spiritual pastoral care resources that our congregations or partner organizations may provide, that everybody is aware of that. When we are gathering for worship, we have a few strategies that can prevent the potential spread of disease. I'm sure many of us have already canceled large events and worship services and replaced them with alternatives like Zoom or video software, video sermons, email communications, and so forth. If we are holding events in person, it's important to stagger or limit attendance in order to maintain that physical distance among congregants. We need to identify traditions and rituals that may need to be suspended, like handshaking. And when changing these events and services, consider the effect on those with access and functional needs. If there's a new location, is that accessible for those with mobility challenges? If we have congregants who are blind, are we describing the services for them? If they're hard of hearing, do we have closed captioning? YouTube can do closed captioning for you on your worship services, which is a helpful tool that I've seen a lot of congregations using. In terms of religious foods and diets, we need to prepare for disruptions to the food supply that may impact our ability to get those foods. For spiritual care, during a pandemic, as a religious leader, you will need to help those who seek your care to reflect on what happened, name and grieve losses, explore doubts and questions about beliefs, and to participate in commemorative events and healing rituals and express emotions. All of this becomes that much more complicated when we're not physically together. You may see a need to deliver food to the sick, offer rituals of healing, visit the dying in hospital, and help with mortuary arrangements. All of these activities while dealing with grieving families. When doing this, we should be following all recommendations by the local health department on how to protect ourselves while providing spiritual care. If we are providing care in person, this may include wearing PPE and physical distancing. For funerals, memorials, and mourning rituals, it's very likely that these will need to be changed and done in different ways. Zoom funerals have become something really popular, and that might mean that you'll then be doing a memorial service for the same person a year or two down the line in order to create that in-person experience. We also want to plan for increased demand during a pandemic situation as people's spiritual and material needs grow. We can list alternative religious rituals and services that can maintain a sense of community when mass gatherings are prohibited, as well as develop partnerships with other faith communities for providing essential social services and ritual life when our resources are stretched. We want to plan for altering rituals that require bodily content or shared ritual vessels. Communion has been a challenge for a lot of communities to adapt. And we want to plan for providing alternate community experiences. We can develop alternative protocols to honor the wishes of the deceased and their families and to prepare bodies for related rituals, as well as alternate protocols for birth rituals. We want to prioritize essential services, develop a protocol for when to temporarily suspend day-to-day operations, such as weddings and birth rituals, in order to concentrate resources on care for the sick, grieving family members, and congregants who develop special needs because of the pandemic, such as children who might be newly orphaned as a result. Now we have the opportunity to share in the chat, or you can unmute yourself and call out. How has your congregation adjusted your services and rituals throughout the COVID-19 pandemic? For example, do you hold services over Zoom? What does religious school look like? How do you celebrate life events like baptisms, confirmations, weddings, and funerals? And what resources do you provide congregants to help them worship or practice rituals at home? All right, you're welcome to unmute yourself if you have anything to add or type it in the chat. I've been to lots of Zoom services and I'm about to join a new member group that would typically be in person, but that will now be happening over Zoom. Matt Schaefer shared that Zoom, Facebook live stream, YouTube, online Zoom classes, online Zoom prayer services, everything is on Zoom. We've all got our Zoom subscriptions rolling. Right, excellent. Jeff Quarter sharing, Zoom is used for almost everything and they live stream worship. As we plan for continuity, we want to help congregations and households both plan. Oh, we've got another answer, Leslie Foltz Morrison, Sunday morning worship by Facebook Live, small video and music team in sanctuary on Sunday mornings. And Crisis Intervention shared that the entire portfolio of worship service is now on a digital platform. I'm curious if a lot of congregations will be keeping their digital platforms up after it becomes safe for people to worship again, if maybe they found it useful for homebound congregants and other people who are having trouble accessing physical worship. When we're planning for congregational and household continuity plans, we want to make sure that if a staff member has become ill or showing symptoms of a respiratory function, that we give them time off or let them work from home. And as well as if a congregant has become ill or showing symptoms of a respiratory infection, that they don't come in to worship and that they're accessing everything they need from home. Staff members or congregants who are ill or have someone at home who is ill during a pandemic should be given the following guidance. Concrete information regarding how long sick staff or congregants should remain home based on guidance from the local health department. We should make sure that others in their household are also staying home when they are sick and following guidance from the local health department for people who were exposed. That we're sharing important information like basic supplies to keep at home, such as fever medicine and other resources that might help with childcare, sharing relevant city, state, or government programs. For example, Test and Trace Core is New York City's public health response to fight COVID-19. Some special considerations we might need to make for supplies and equipment include acquiring personal protective equipment, acquiring the appropriate technology like computers and Zoom subscriptions, hygiene supplies like garbage bags, cleaning supplies, hand sanitizer. We all remember when those things were sold out, and ritual items or materials that might need to be delivered to congregants' homes for their worship purposes. When planning for continuity, it's extremely important that we account for additional costs. None of the actions taken in the previous sections can be successfully performed unless you plan for the cost to your congregation or faith-based organization. Additional supplies, communications, overtime, or any other additional items or actions may have costs associated that your congregation or faith-based organization may be challenged to afford. Consider the costs from the actions that you might take in preparing for or responding to a pandemic like COVID. Some costs may be one-time only, while some may recur on a yearly, monthly, weekly, or even daily basis. Also consider income that your congregation might lose during a pandemic, such as lost rent or reduced donations. Before proceeding with any of the actions that you identified in the previous sections, answer the following questions before making a purchase or taking an action. Does my staff need this to continue to function? Will not having this put people's health at real risk? Is my action or purchase based on facts? And will my community actually use this? When planning for continuity, we also need to consider mental and spiritual health. Mental health and spiritual pastoral care are of particular importance during a pandemic, as these can be times of high stress. We should encourage staff to look to one another for emotional support during a pandemic scenario. Consider instituting a buddy system where each staff member can be assigned or choose someone to provide dedicated peer, psychological, emotional, and spiritual support. Also consider the following self-care tips for you and your congregation staff. Taking care of your body, getting enough sleep and rest, eating healthy, exercising as much as you can, avoid drugs and excessive drinking and smoking, taking care of your mental health, learn about normal and abnormal reactions to the disasters, don't ignore your own emotions, know when to seek help, taking care of your spiritual self, making time to reflect, meditate, pray, find spiritual connection or community, and increasing your resiliency. Do something that will help you regain a sense of control. Focus on your strengths and positive coping skills. Reaching out. If you feel overwhelmed, reach out, express your feelings. Don't be afraid to accept help. Remaining active. Sometimes it helps to have a routine, and going back to our normal activities as soon as it feels comfortable and safe to do so is part of that. Managing your workload. Maintain a healthy balance between your work and rest. Take breaks and time off. Prioritize your tasks. Reducing your stress. Do things you find comforting. Exercise, read, and listen to music. Be with people whose company you enjoy. Practice stress-reducing exercises. The following actions might help your leadership to delegate when they feel overwhelmed. You might work with a judicatory religious network or partner. Consider a congregation that has a similar mission to help you share your leadership. Combine your activities in a way that allows leadership to share responsibilities and split time. If your congregation or faith-based organization has other branches in different parts of the region or country, consider working them to have leadership from a less affected area come in to help. Although at this point in the pandemic, the virus is so widespread that this usually isn't an option anymore. If possible, plan to have leadership work in set rotating shifts, allowing one member of leadership to rest while another leads. You can find more tips on New York City Well on recognizing stress and staying mentally healthy. We can share in the chat, how have you been practicing self-care throughout the COVID-19 pandemic, and what policies or practices have you put in place to encourage self-care among your staff? You're also welcome to unmute yourself and call out. Something I've been doing in interest of my own self-care is a daily stretching ritual. I'm spending a lot of time sitting, and it's important that I'm able to stretch out my shoulders at regular intervals. Taking walks is one that we've seen come up in a lot of webinars as well. Yep, making sure to get enough sleep, that's really important. Sometimes when we're spending so much time in front of screens, that blue light can irritate our eyes and also make it harder to fall asleep. In my case, I've invested in blue light blocking glasses to help me with that. Some safety net folks to talk to and vent. It's really, really important that we have those people who we can trust unequivocally, who are there for us in case we need that support. can be a really hard one to find as clergy when so many people in our immediate environs are the people depending on us for that. Great, these are some great answers. Thank you everybody for participating. Included in our supplemental documents are continuity planning and communications planning, and each of them have two main bodies therein. Continuity planning has the current organizational chart and identification of organizational functions, while communications planning has planning your pandemic communication and the pandemic communication message template. We've now reached the end of the toolkit section of the webinar. We still have time for vaccine updates, and we'll still be having our speaker from DOHMH joining us. But if you have any questions on this section of the webinar, I'm happy to field those now through the chat or by unmuting yourself.
I wanted to point out, Gabrielle, some earlier comments from the chat where we had discussion of the benefits and negatives of Zoom, where some people do plan to continue using it since they get many more participants, and others also acknowledging that there are some access difficulties where not everyone has access to services on Zoom.
Yes, that's definitely a problem because not everybody has a computer or an iPad at home, and not everybody has a fast enough internet connection. So I definitely wouldn't support us permanently switching over to Zoom. But I'm intrigued to see that some folks have commented that they will continue using these platforms afterwards. Okay, if I'm not seeing any questions, then I'm happy to move forward with the vaccine section of the webinar, and we should be joined by DOHMH in about 10 minutes. As I'm sure most of us know, two COVID-19 vaccines, the Pfizer-BioNTech and Moderna vaccines, have been approved for emergency use by the Food and Drug Administration. And in clinical studies, both vaccines were more than 94% effective at protecting participants from COVID-19. This graphic shows us how a new vaccine is developed, approved, and manufactured, that there are 3 phases of the clinical trial. The first phase includes just 20 to 100 people, but by the time we get to phase 3, we have hundreds or thousands of volunteers. In these cases, it was tens of thousands. The vaccines are made in batches called lots, and manufacturers must test all lots to make sure that they're safe, pure, and potent. The lots can only be released once the FDA reviews their safety and quality. The FDA also inspects manufacturing facilities regularly to ensure quality and safety. There's been a lot in the news this week about using the Defense Production Act to increase vaccine production. And one of the obstacles is retrofitting other biomedical production facilities for the production specifically of this vaccine, because it does need to meet such strict quality assurance requirements. Are the vaccines safe? The COVID-19 vaccines have gone through various clinical, various clinical trials and studies involving tens of thousands of people of various ages, races, and ethnicities. The Pfizer vaccine includes over 44,000 study volunteers, and the Moderna vaccine included over 33,000 study volunteers. And the evidence from those studies was closely reviewed by the FDA as well as independent organizations. We're also sharing with you some demographics from those vaccine trials. This is for Pfizer-BioNTech. you'll see that 82% of the participants were white, 9.8% Black or African American, and 4.4% Asian, 2.5% multiracial, a small group, 0.6% of American Indian or Alaska Natives, and 0.2% Native Hawaiian or other Pacific Islanders. While these demographics don't match the composition of the United States as a whole, and certainly don't match the composition of people who are disproportionately affected by COVID, we do know that great lengths were gone to make this one of the most racially diverse vaccine trials that has ever been conducted in this country. And it is better than most demographics from previous trials. You'll see very similar demographics for the Moderna trial. And there's no evidence that the vaccine affects different racial or ethnic groups differently. I think that's very important that people are aware of. It was also pretty evenly distributed according to gender, as well as according to age. In terms of safety, the vaccines are safe. You can't get COVID-19 from the vaccine because it does not contain the virus. It teaches your body's immune system how to fight the virus, so it can fight the virus if you are exposed to it. Researchers have been working on vaccines for coronaviruses for years, so they didn't start from scratch. It's important to understand that while mRNA is a new type of technology for vaccines, it has been studied for over 30 years. As of Monday, January 11th, and continuing today, the following groups are eligible: at-risk healthcare workers, people ages 65 and older, residents and staff in nursing homes and certain other group living facilities, as well as certain frontline essential workers, such as first responders, teachers and school staff, daycare workers, transit workers, and grocery store workers. This is a chart that goes into greater detail with that eligibility, and you can find this chart on the New York City Department of Health and Mental Hygiene website. The vaccine is free for everyone. If you have insurance, it might be billed, but you won't be charged a copay or other fee. Our DOHMH speaker from last week informed us also that sometimes the portal is a little glitchy in terms of accepting insurance information, and if you're having trouble, you can click that you don't have insurance even if you do, and you'll be able to make your appointment that way. You don't need to share your immigration status to be vaccinated. Getting vaccinated is not a public benefit under the public charge rule. When you receive the vaccine, your privacy will be protected. There are strict laws in place to ensure confidentiality of your personal information. In order to make an appointment, there's no walk-ins, so you will complete the New York State COVID-19 vaccine form and then schedule your appointment via the vaccine finder or by calling the vaccine hotline. And it's important to remember all of the normal safety precautions when going to the appointment, like wearing a face mask and practicing good hygiene. In terms of finding a location, if you're eligible, you can use the vaccine finder. You can type in an address, zip code, or search near me to find a list of nearby provider locations via GPS. And each vaccine site manages their own schedules and appointments. So it might involve doing a lot of phone calling around to different pharmacies in order to find an appointment at a given location.
Just to interrupt for a second, Gabrielle, I think it's important to note that every state is managing vaccine distribution separately. So what's happening in New York City or other counties or other states is different. A lot of states are using the CDC's VAMS system, which is their vaccine management system. New York is using its own system.
Thank you, Peter. That's a really important point, that this is only viable information for New York State. They've sort of come up with their own system for helping people get appointments. So if you're from out of state on this call, I'm sorry, but you're out of luck with this particular aspect. This is the latest tracking information for the doses administered. You can see that at this point, 611,593 persons have been vaccinated by NYC-run programs, and many of them have also gotten their second dose, and a smaller number have been vaccinated through the federal long-term care facility program that is operating in New York City and also elsewhere. We still have less than 74,000 doses of dose 1 on hand, and then 336,000 dose 2. That will be held in reserve for that group of people that has gotten dose 1 but hasn't gotten dose 2 yet, and they always make sure that they'll have a dose 2 available for you if you've already had dose 1, so you shouldn't worry about them running out of vaccine in between your 2 doses. Potential side effects. Common effects include soreness or swelling on the arm where you got the shot, headache, body aches, tiredness, and fever. They're usually mild to moderate and start within the first 3 days after getting the shot. The day after vaccination is the most common, and then they last for about 1 to 2 days after their onset. They're more common after the second shot and less common in older adults. Susan and I were on a webinar with Dr. Wayne Riley from SUNY Downstate Medical Center, and he let us know that he had gotten the vaccine and that the side effects resulted in some fatigue for him that lasted about a day, but that in comparison to other vaccines he's had, such as the shingles vaccine, that it really was a piece of cake. I'm wondering if anybody in the audience has already gotten the vaccine and might want to share their experience.
I got the Pfizer vaccine from Hospital for Special Surgery, and I already have physicians there. So I got a text message inviting me from HSS, inviting me to get an appointment for the vaccine. So I appreciated that because I'm in the H category. But they did make me fill out all my insurance information, which was confusing.
Yes, I agree that it's really confusing that they're having people fill out insurance information even if the vaccine is free. My understanding is that's being billed for administrative costs, not for the vaccine itself. Right,
because the vaccine, if you look up the quote unquote price for the drug, it was reported in Wall Street Journal in November that the drug actually only cost $20. But obviously there is staff costs and setup costs and refrigeration costs for the hospital to give me the shot. But what they still fail to say anything about was give me a ballpark idea of how much they're going to bill my insurance for giving me that shot.
Right. Those reimbursement levels shouldn't be too high, but it's something that I think is important. It's important to point out that this needs to be really clear that although the vaccine is free, in some cases they will bill your insurance, but if you don't have insurance, that we shouldn't be worrying about it, that nobody should be turned away for a vaccine for lack of insurance. Thank you for calling our attention to that. I also see that Odessia Brown shared in the chat that I got the first dose of the Pfizer vaccine at work. I'm a social worker at a hospital-based outpatient mental health clinic. And I'm assuming from both Leslie and Odessia that your side effects were mild to moderate, nothing catastrophic happened.
Yeah, that was.
If you do have side effects that concern you or don't go away after a few days, or if the redness or soreness where you got the shot increases after 24 hours, you should call your health provider. And you can also talk to your health provider about taking an over-the-counter medicine like Tylenol or ibuprofen to relieve pain or discomfort. After vaccination, this is really important, you still need to practice prevention measures. That means staying home if you're sick, staying at least 6 feet away from others, and wearing a face covering when you're outside your home, as well as practicing great hand washing hygiene. This is because, like all vaccines, COVID-19 vaccines are not 100% effective, and we still need to learn more about how long protection from the vaccine lasts and the impact of the vaccine on disease transmission. It's a live question whether people who have been vaccinated could potentially still transmit the vaccine without getting the information. It's important to stay informed and listen for information from your public health officials. So we've already talked about Leslie and Odessia's experience getting the COVID-19 vaccine. If anyone else wants to chime in, you're welcome to now.
Hi, I just want to share that most of the people I know who got vaccinated either with their first or second dose has 0 to mild side effects, but I do know someone who ended up being hospitalized after they got vaccinated. I know that there have been several reports about people getting some kind of allergic reaction, but I have yet to see anything to kind of clarify what is it exactly that might be in the vaccine that might be causing the reactions. I don't know if there's been any more data on that, but I'd be curious to just see if there's been any more information about what exactly might be causing that reaction in some folks.
Sure, thank you.
There's the CDC website has a list of the active or the reactive ingredients in the vaccine. I got a copy of it when I registered my mother for the vaccine. If I can find it, I'll send it to you, Richard.
Thank you.
Great. And yeah, and that's a question that we can hold on to if we're joined by DOHMH.
I think we should also note that you get a vaccine card when you get the vaccine that tells you which vaccine you got, so that when you get your second dose, you get the same vaccine. There's been some controversy about whether or not you can get the second dose of a different vaccine, and the information seems to be pretty clear that you're supposed to get the second dose of the same type and not switch types. I think I have to say, from the experience of taking my own mother for the vaccine, she's in her 90s. I think it can be a little bit, some of the instructions can be a little bit confusing, some of the information a little bit confusing. So if someone is prone to getting confused about that kind of information, having a companion go with them is definitely advisable. The reaction is similar. The allergic reaction is an anaphylactic reaction. And so it is obviously dangerous if somebody has it, but it's happened in a very low percentage of cases. I think all of us are capable of Googling the vaccine studies, but the reactions, the negative reactions, side effects to the vaccine are very low. And I don't think that's paid a lot of attention to in the media, and I think it's scaring people a little bit about, that they're going to have a reaction. My mother's very, very allergic to bees, so she was super afraid of the vaccine, but the nurse, at the vaccine center in Connecticut where she went was very reassuring and said, allergies to insects and things like that are not an indicator of reaction to the vaccine. It's really a chemical, in the vaccine that some people might be reactive to. But again, I think it's important to be more reassuring and emphasize the fact that the reaction levels are low. People who aren't necessarily getting reliable information from the news or Facebook about the vaccine. So good information from the health department, the CDC, or asking questions at the vaccine centers of the nurse who's there, I think are the best places to get the information.
Thank you, Peter. So Father Papachak shared that his wife and younger son received both doses and had some headache and other side effects for 36 hours. He's on the wait list. And in response to your question, Suzanne, the vaccine is 94% effective. So unfortunately, there is still the possibility of infection. Our speaker from DOHMH is here. I'd like to introduce Hannah Arnett, and she'll be able to answer some more of your questions and give some more information from her perspective about the vaccine. Hannah, are you with us?
Hi guys. I was just scrolling through the list to see if I knew who any of you all that, because I haven't been on one of these in a while. So as I understand it, I'm not giving a formal presentation today. I was just on to answer some questions, and it sounds like I jumped into you all talking about allergic reactions to the vaccination, and I'll just give you just a little brief on what I've been doing the last couple of weeks. I've actually been working in one of our vaccine sites, the one in Bushwick. At this point, I'm guessing I've probably overseen more than 10,000 vaccination shots at this point, and we've yet to have an allergic reaction to one. Typically, we have 3 or 4 people a day that we will call the EMTs who are stationed on site at vaccination to talk to someone, and every single case has been anxiety, so which is completely understandable. This is a new vaccine, and I think, I mean, notwithstanding, I will speak for myself. I get a little angsty about getting shots anytime, no matter what needle it is. But yeah, usually we have to talk to a few folks every day just through their anxious feelings after receiving the vaccine. But we've not actually experienced, you know, just to give you an anecdotal, what I'm seeing on the ground happening. I think it sounds like someone's family had some maybe mild symptoms. I think especially one of the things we've been seeing just in the folks that, you know, we work with is that people who've had COVID-19 tend to experience some side effects from the vaccine, maybe a fever, feeling achy, those types of things for a day or two after the vaccine. And typically people who have not had COVID have a sore arm, like you do when you have the flu shot. So yeah, if that's helpful to anyone, but happy to answer any questions or yeah, give any feedback or anything that you all are interested in.
Thank you, Hannah. Does anyone have any questions that you would like to share in the chat, or you can unmute yourself and chime in? We had a question earlier, Hannah, about the possibility of getting COVID-19 after both vaccinations. My response was it's 94% effective. So yes, there's that possibility, but if you might go into more detail about that.
I can tell you what I know at this point, and I think there's still, you know, we're still learning about this, but as far as I understand it and what, you know, I've been discussed, so I'm not a medical professional myself, but I work side by side with infectious disease doctors at the Department of Health. And like I said, I've been actually in one of our vaccination sites for almost 3 weeks now since we started that, so working very closely with a lot of medical professionals on this. As I understand it is, you know, what they're trying to still somewhat unclear on is whether or not you can still be a carrier of COVID-19 after you've had both vaccinations. So, you know, I think it's important to remember that, especially as things are, you know, popping into the media, that so I've had my first dose of COVID. I could still get COVID because I'm not 2 weeks out from my second vaccination, and 2 weeks, you know, is 2 weeks is the number that we give, but some people's immunities are going to pick it up a little quicker and some people's are going to be a little bit slower. So that's really, you know, a general window of time. But just because, so once I get, you know, or once anyone gets through, you know, you're past your 2 weeks, past your second vaccination, there is some thought that you could still carry COVID-19, although you won't actually have symptoms of it yourself. So if you were to have it, it would be asymptomatic. And I think a lot of questions are coming right now because I think there's a government person, maybe a senator or a congressperson, who tested positive for COVID-19 after the second vaccination. I just was actually told about that last night because we've been in the vaccination pods, and I have little been out in the rest of the real world. But I haven't heard yet whether that person was outside of their 2 weeks. But it is technically possible that you could be potentially a carrier, and that's why we will still wear our mask after we receive our second vaccination. We will continue to do that because most people are not vaccinated, and we're doing it to protect others. I know, I think we have to be careful, especially as leaders. And I would say this to health professionals because I'm seeing really mixed conversations happening in the media. 94% is incredibly high for any vaccination. It's a real win. And I think we need to be careful about how these conversations are and not make people feel afraid that after they've went through the process of being vaccinated, that they still have to live in fear. Because we know that the vaccine is 94% protective, and we know that if you have the COVID vaccine, you're not going to die from COVID. And the worst impacts of COVID for yourself will be eliminated. And I think it's really important because we want people to get the vaccine. It's super important that people get the vaccine. And it's super important that we not encourage people to continue to live in absolute fear that we have become very conditioned to live in this year after receiving the life-saving vaccine. Because yeah, I'm seeing a lot of conversations like that. And, once you have your second vaccine, you're gonna be safe, you may not, like I said, you may, be able to still pass it to others. We're still unclear. We need a little bit more time from that, but it sounds like preliminary testing has looked pretty good on that.
There was a follow-up question. Richard Espinal writes, everything I've heard is that none of the vaccines prevent infection, but prevent moderate to severe symptoms. So Pfizer, Moderna are 95% effective in preventing the symptoms, but not infection. And he wrote that Congressman Espelay got infected before the second dose kicked in. Can you comment about whether these vaccines are preventing infection versus symptoms?
That's a technical question that I would have to go back to the medical people and get you a technical answer for, because I don't want to give you information that may or may not be correct, because I hear these conversations all the time. But like I said, not being a medical professional, I would want to make sure I communicated that to you properly. So Richard, I'm happy to go back, to an actual infectious disease doctor and get you an answer for that and have NIDIS communicate it to you. I think it's a great question. As far as I understand from the testing and from, what we're expecting is that if anything, people would be asymptomatic, but it is new. And I think, it's going to take some time to fully understand all the things, but I would like to get you a better answer than my, best estimation as a non-medical provider on the information I've read and the conversations I've heard.
Thank you. We have another question, which are trusted messenger questions in context of the COVID-19 vaccine appointment process. Could the person who asked that question elaborate a little bit on what related to being a trusted messenger, or if? Mm-hmm.
Yeah, thank you for amplifying that. The question is simple. We understand that many persons in various communities are looking to get the vaccine, but have had unsuccess probably because of the outflow of what was not available, given some bottleneck in supply. But we recognize that especially our vulnerable populations are looking to take the vaccine and having problems with getting the actual appointment. And I think DOH has put in their playbook an Audible to work with faith leaders to help facilitate that process. Is that something that's going to happen, and I don't have all the details because I'm just hearing and learning about it in real time.
I want to make sure I have your question right. Are you asking about if they're doing improvements to the hot mess of a rollout that it's been? Because
That's what it comes down to, yes.
Yeah, like that's no secret. So
there's been some bad PR about it.
Yeah, if you want to ask me straight, you will not offend me.
So yeah, we're hoping that there's some refinements, and that would maybe include faith leaders to help with the process, because there were people getting vaccinated from out of state in our city resources. So what can we do to help?
Right. Yeah, no, that's been a huge problem. And I think a lot of us on the ground had really been calling that out early, because, what we've seen, I can say, especially, I've been in Bushwick, and I think, it's not perfect, but we haven't had the extreme problems that you've seen in places like the Bronx. And, I've asked some of my other colleagues working at other sites, and literally, I know the news story blew up about Washington Heights, but, most of a huge majority of the people showing up at a lot of our city sites are also white people from upstate or Long Island. So I asked colleagues about the Bronx. The Bronx South Bronx has been mostly white. Come on, we know that's not. I asked folks about Canarsie, mostly white. When is that happening? Even East Harlem, I've heard, has been very, very similar, like mostly people who are white with questionable that they're New York City residents are the people that are coming to get the vaccine. I think one of the things that is a particular challenge when trying to sort that out, not necessarily like the issue with race, but the issue with people with coming up from upstate, is that we want people who are undocumented to be able to feel comfortable coming to the site. And so there's been a lot of conversations about how to identify, how to ask for identification that doesn't alienate people from coming, but also helps prevent what we're seeing now. And that we really only want to be vaccinating New York City residents, because that's going to help our herd immunity. So yeah, I think that conversation is happening. I think for you all as community leaders, I would say keep the pressure on us. I think, a lot of times, I don't know if I know you all who are on the call, but those of you who've been on things with me, I'm like, hold us accountable all the time. We need you all to hold us accountable, hold the mayor accountable, hold the Department of Health accountable. Like, your voices are oftentimes more powerful than those of us who are advocating on the inside and can help make change. Because the issues, I'll speak to what finally made the news, this weekend. The issues with racial, disparities are exactly what we knew was going to happen. And what we've seen, I can tell you what I've seen visibly play out with my own eyes. And it's a mix of, access, but it's also a mix, I know there's a lot of vaccine hesitancy where we do really need you all, and we need the Department of Health, and we need the city to be putting out more nuanced information so people can make informed decisions about their lives. I think you all know as well as I know, telling people to get their shot really doesn't do anything. That we have to give people real meaningful information to counteract a lot of the lies and misinformation that's been spread around about the COVID-19 vaccination. And I think one of the biggest things I hear, I'd be interested if this aligns with you all, but one of the biggest things that we hear is why so fast? And I think, there's several tiers to the answer to that. Part of it is just, there's been a lot of development in scientific process in the last, few years. We were able to even have a test to identify COVID in record time, like time we've never seen before. And I think a lot of those technological advancements apply to the vaccine, but because COVID-19 belongs to the family of viruses that is coronavirus, so coronavirus is a large family of viruses that can include even a virus like common cold, there was a lot of, pre-development on different types of vaccines that they were able to, already have, that they were able to build on top of. And I think with the Trump administration using language like fast track really only applied to funding. It did not, and the funding makes things move quicker. You don't have the barriers of having to slow down. We've had, a huge access to money to be able to move these vaccines along a lot faster, but there's been no fast tracking when it came to the approvals process for the vaccine. Everything went through the normal protocols that they would go through before going to the market as they are currently. So, I think the more that you all, can partner with us to help spread the information, but I think the more you all can continue to ask us to give you the right kind of information and point out when we're not giving you what you need, is really helpful.
Thank you, Hannah. We have another question. Vaccine supplies are only trickling in now. When will we get doses in sufficient quantity to really make an impact?
Yeah, I wish I knew the answer to that, but I will say I feel more hopeful with the new federal administration, with the Biden administration in place. I think they seem committed to really moving things along and removing barriers and having an organized federal response to the COVID crisis. So hopefully we will be seeing improvements now. I think, the conversation is really around, we would like to see the majority of people vaccinated by this summer. So hopefully that means improved supply soon. I think I just saw maybe something in my email box that maybe the Biden administration even today was talking about producing more doses of vaccine. So yeah, I feel confident that we should see things move quicker now, but I don't have any exact information that I can share with you. I wish I did. If I did, I would share it.
Thank you, Hannah. We have another question, and this is not the first time this has come up in a webinar that I've been on. Internet and phone appointments do not work for a lot of our community members. Is there a possibility of making appointments in person?
Yeah, so you're absolutely right. And there's a lot of advocacy that's happened, I would say internally, to identify this as an enormous problem and an equity issue. I know you all don't need more work to do, but I think that also falls into the category of keep pointing this out to the city through relationships that you have, social media, things like that, because it is true. We really need an in-person walk-in policy for these vaccination sites, because so the way it is right now is that officially we're not really allowed to do that, but I think it really depends on who's running the sites, who's willing to bend the rules a bit in the direction of justice, but that's not really the best practice. We really need that to be offered to people, and recognize that language barriers and age and things like that are real barriers to people getting their vaccination.
Absolutely.
I wish I could give you a better answer.
Our next question is, would it ever be possible for seniors, differently abled persons, and homebound individuals or persons with underlying conditions to receive vaccines at home?
Yeah, it's a great question. I don't know the answer to that. I know that some other jurisdictions, I believe, have begun doing that. I'm going to feel like a broken record of advocacy here and saying, please keep holding us accountable, keep pointing this out to the leaders. But I will give you something so I worked the measles response for the Department of Health, and I'll tell you something that might be useful to you, information that during the measles response, we were able to pilot and stand up a new operation, which was a partnership with visiting nurse services to do private in-home vaccination. So we were able to do a contract with visiting nurse services, so they were able go into homes and offer vaccination. At the time, that was really because for some of our Orthodox community members, there was stigma around getting vaccination, and those who wanted to get the vaccine, we wanted them to be able to do it without having, pushback from their community. But it seems logical that that could be a possibility for the COVID vaccine as well, because it really is for our older, especially for our older, more vulnerable people, or people who just aren't unable to leave their home. But even for those who are, and they're taking on a certain amount of risk to show up to a congregate setting to receive a vaccine. Yeah, I think that makes a lot of sense. And sadly, I'm going to repeat back to you again that sometimes your voices are heard more than the internal advocacy around these things. So, but yeah, there is precedent. It would be great to see that again.
Thank you very much, Hannah. This was addressed also with Dr. Ige last week, and she let us know that there are plans in the works to get vaccinations into people's houses, but that's not yet possible exactly. And we have another question, whether you can answer regarding whether private hospitals can charge an administrative copay. Who permits that, the state or the city? Can private hospitals be required to say that up front?
You know what, that is a question that I would have to go back and ask someone, because I don't work with the private hospital system. I don't know I know that, so basically the COVID vaccination should be 100% free, but I don't know how private healthcare works. So in terms of that, I don't know if they have a different type of structure where they're able to enact a fee on something that should be 100% free, but I would assume no. But I can't confirm the answer to that. But, as far as I understand and all the things that I know, that the COVID vaccination is completely free. And some of the forms, the older forms, I think they're fixing this now, have asked for, and if you go on the app, it's asked for insurance information, but you do not have to give your insurance information. In fact, you should not. Vaccine is completely free, and we do not need anyone's insurance information to be able to complete that. It was an issue with the app when it was stood up, asking for information that we did not need. So I think that's getting corrected. There's supposed to be a new app that's launching. It was supposed to launch this weekend, but you know how new things go. That didn't really happen. There was some tech issues with the new launch, but there's supposed to be a new, more streamlined app that edits out some of this stuff, launching in the next few days.
Thank you, Hannah, for that update. We're getting very close to time. Unless we have one more urgent question, I would like to thank Hannah Arnett for your time and your ability to be here with us during this extremely busy moment in the Department of Health's life. And I'm so grateful to everybody who has been on this call. There's a lot of additional resources in this PowerPoint that I'm going to skip through now, but which will be available when we email you the PowerPoint. You'll have this in your inbox so that you can go through all those resources at your leisure. A quick reminder about other upcoming webinars in this series. We have one for Muslim leaders tomorrow, one for Buddhist and Hindu leaders on Thursday, a webinar coming up in Spanish on February 9th for Christian leaders, and a webinar for leaders of any tradition, again in English, on February 11th. All right. We want to remind you also to do the evaluation that we'll send to you. That's really helpful feedback for us in continuously improving the services that we provide. And I'm again grateful to the Archdiocese, the Greek Orthodox Archdiocese of America, and the Salvation Army of Greater New York for their support, as well as the New York City Mayor's Center for Faith and Community Partnerships. Thank everyone for being here today, and we look forward to seeing you again at future events.
Thanks, everyone. It's great to be with you.